Good afternoon, everyone, and thank you for joining. Today, we're going to dive into the OIG work plan and review three key areas we're all going to want to be sure we include to our 2021 compliance plans. We're going to explore telehealth, laboratory billing for COVID-19 add-ons, and the 2 midnight rule. Before we do that, I want to take just a few minutes to talk about who the OIG is and what their responsibilities are. In 1976, the Department of Health and Human Services established its Office of Inspector General. The main responsibilities are to combat fraud, waste, and abuse for Medicare, Medicaid, and the remaining HHS programs. Kind of a fun fact, the HHS OIG is the largest Inspector General's office in the United States government. I thought that was kind of a neat fact. The majority of the OIG's resources are focused on overseeing Medicare and Medicaid programs, and they do this through audits, through investigations, through evaluations, all of which are designed to promote cost savings, and they assist with identifying areas of opportunity and also policy recommendations. The OIG work plan is published yearly with monthly updates. Typically, there are updates throughout the month. It describes the OIG's priority over the coming year and beyond. And when we talk about their priority, we're talking about their focus. What are they auditing this year? What are they focusing on? Projects described within the work plan include CMS, public health agencies such as the Center for Disease Control and Prevention, National Institute of Health, Administration on Community Living, and HHS. A lot of people don't know this, but the OIG also plans a lot of work related to the state and local government's use of federal funds and also functional areas of the Office of the Secretary of the Health and Human Services Department. The OIG work plan is such an important tool for us as leaders. It helps us establish robust compliance programs, but it also serves as a foundation for risk assessments within our organization. So, as leaders, we always know that there are areas that we want to focus, and we have a plan every year of what we really want to focus on or where we want to conduct our reviews. But it's important that we also add the Office of Inspector General's work plan to our compliance plan, so we know that we are protecting, we're being proactive, and we are eliminating as much of the risk that we can for our organization or our facility. I don't know about you guys, but I was not the least bit surprised to see telehealth make the OIG work plan this year. The COVID-19 pandemic really increased the demand for telehealth services, and CMS really stepped up to the plate and implemented numerous waivers and flexibilities that allowed Medicare patients to obtain care through telehealth services where typically they probably wouldn't have been able to receive care. They expanded the range of providers who could provide telehealth services. We saw physical therapists, occupational therapists, speech language pathologists be able to provide services to patients that really kind of help the continuity of care. It was really a great benefit to be able to add those flexibilities and engage patients with continued use in these areas, continued service in these areas. In January of 2021, CMS announced their plan to include Medicare telehealth Part B audits. I really wasn't surprised to see this. They're dividing this into two phases, and one thing that has been pretty clear as I've researched this more, phase one seems to be a pretty quick review. Some of the literature out there suggests that they may even review as few as 10 charts per service. But the idea here is to do a kind of fast review, dig in, see if there's a need for further investigation. Phase two is going to be more in-depth, robust review, where they look at services related to distance and originating site locations, virtual check-ins, electronic visits, remote patient monitoring, the use of telehealth technology, and then also annual wellness visits. A couple things I want to point out. I really don't know how much attention they're going to pay to services related to distant and originating site locations right now, because April 30th, CMS implemented a waiver that really relaxed the restrictions around distant and originating site locations. So, I think while we're designated in this public health emergency, they're probably not going to pay a lot of attention to those particular aspects of the phase two review. As we moved into 2021, CMS finalized 114 Category 2 codes. Now, these codes here are just an example of some of those codes, but these codes can all be used outside of the CMS normal restrictive distant and originating site requirements. and they're eligible for all the flexibilities and the waivers that CMS implemented. When we look at the expected controls, there's a lot of things here that is just, normal business. The documentation guidelines are very clear as to what is expected within the medical record. When we look at phase 1 expected controls, we know that the reviewer is going to be looking for whether there's documentation in the record to say whether the visit was a phone call, FaceTime call, or a telehealth call. The provider must have documentation somewhere, or the reviewer must be able to see that the provider used interactive audio and video telecommunication system that permitted real-time communication between the provider and the patient at home. And of course, we know that this must be a HIPAA compliant platform. They're going to look to see that the place of service was documented. A couple things here we need to be aware of. Medicare prefers that the place of service is the place where the patient would have had the service performed if he or she would have presented in person, and then assigning that 95 modifier to identify the telehealth service. They're going to look to make sure that the nature of the complaint and the chief complaint is documented, as well as the final diagnosis and treatment plan. The purpose here is that when we go back, or anybody goes back to look in the medical record, we need to know that we understand why the patient came in, what their symptoms were, why they sought out care, what our treatment plan was, and why and what the final diagnosis was. The reviewer is also going to look to make sure that the appropriate modifier is assigned. Again, we go back to that modifier 95 as an example. And then lastly, that the patient approval and consent is noted somewhere within the documentation of the record. Something that's a little bit different for us to make sure that we take note of when we look at our end-stage renal disease patients, these patients do not have the flexibility to only have a telehealth visit. One visit per month must be a hands-on inpatient in-person visit where a physician or a nurse practitioner or a CNS can actually examine the patient. And the reason for this is because many of these patients have vascular access ports or devices that need to be examined. So for end-stage renal disease patients, one visit a month must be in person. When we look at telehealth opioid expected controls, we know everything that we already talked about has to be documented within the record, but there's a few things that are a little different. So we all know that doctors were already allowed under federal law to use telehealth services to prescribe controlled substances, but in the past, it had to be an established relationship, so it couldn't be a new visit. Under the telehealth waivers, the first face-to-face meeting requirement is waived. So a new patient or an established patient can be seen. And these exemptions also apply to both new prescriptions and renewals, provided that these three conditions are met. The first one is that the prescription is issued for a legitimate medical purpose and that it's prescribed by a practitioner in the usual course of their professional practice. So a licensed physician that has a DEA number, he's certified through the DEA to write prescriptions, just the typical standard rule. The second thing is that the telemedicine communication must be audio and visual. It has to be a two-way, real-time interactive communication platform that's being used. It's not acceptable to only have an audio system, audio and visual. And then last, the practitioner is acting in accordance with federal and state laws. So, an example would be if a certain prescription is not permitted to be written while the patient is in an office setting, it's not permitted to be written when the patient is in a telehealth setting. So those things we have to make sure that we pay close attention to and that we comply with the federal and state laws that have been set forth. When we look at expected phase 2 controls, one rule here that we have to make sure that we're following is the telehealth rule that states that the physician and the patient cannot be in the same location and the physician still bill or conduct a telehealth service visit. If the patient and the provider are in the same location, the physician must see the patient. So if the patient and the provider are in the same building and the physician decides that he does not want to see the patient in person because he wants to avoid the risk of exposure to COVID-19, he is not permitted to bill a telehealth service. They have to be in two separate locations in order for the provider to bill a telehealth service. When we look at the rule for virtual check-ins, they're really pretty simple. The patient must be an established patient to the practice. There has to be 5 to 10 minutes of medical discussion documented within the medical record. If the service originates from a related evaluation and management service that was provided in the previous 7 days, or it's going to require a visit in the next 24 hours or the next available appointment, the service is bundled into the E&M service. Verbal consent must be noted within the medical record for each service, and the physician must document that in the medical record that the patient does not need to come in for a follow-up unless there is a problem. And I feel that that's probably a control that they will be looking at. You know, when we're doing these virtual check-ins, we have to be able to still manage the patient and monitor how they're progressing with any type of illness or a chronic condition that they may have. So it's going to be important for the physician to document when he does this check-in that the patient does not need to come in for a follow-up unless there's a problem. The annual wellness visit is really pretty straightforward. This can be audio only, and it can be initiated by the provider or the clinical staff person, really just calling the patient and letting them know that their annual wellness visit is due. It can be carried out completely by a clinical team member under supervision, of course. And one thing that we have to remember is that there is no copay or coinsurance for these visits, and I have a feeling that the OIG will be watching that. And you know, I think an important thing here is this last bullet when it talks about including patient education on health risks. You know, the whole point is whether the patient is in a telehealth setting or they are in office setting, they're going to look to make sure that we're still personalizing care to the patient so the patient receives the value out of it, the same value that they would have received if they came into the office. So are we doing a depression screening if it's warranted? Is there diabetes self-management training? Is there medical nutrition therapy that's needed? All of those things still need to be assessed, and we still need to make sure that we're providing the same type of care and the same quality of care that we would have provided if they came into the office. And then again, making sure that it's documented. When we look at remote patient monitoring coverage here, right now we're in the middle of a public health emergency. So because of that emergency designation, the provider and the patient does not have to have an established relationship. Once that public health emergency designation ends, the provider and the patient will have to have a relationship. So while we're in the middle of an emergency, it doesn't matter if that relationship is there or not. It can be a new patient. It can be an established patient. They can receive consent for the monitoring at the same time that the service is being furnished. Ancillary personnel can provide these services. And just as a reminder, when we're talking about patient monitoring, we're talking about blood pressure, weight, pulse ox, respiratory rate, education on some type of patient equipment, initial setup of a device. Something like that falls to the 99453 and the 99454. And these codes are incident to the billing practitioner's assistance and under their supervision. After the public health emergency ends, we are going to have to be able to collect and transmit 16 days worth of data every 30 days in order to meet the requirements to bill CPT codes 99453 and 99454. So we're going to want to make sure that we keep that in mind. And as we near the end of this, hopefully we are nearing the end of this public health emergency. But once it concludes, we need to make sure that we are collecting and transmitting 16 days worth of data every 30 days in order to meet that requirement to bill for the monitoring services. Only physicians and nurse practitioners who are eligible to furnish E&M services may bill for monitoring coverage. And we need to remember that these RPM services are medically necessary for patients with acute conditions as well as patients with chronic conditions. Moving over into laboratory billing for COVID-19 add-on testing, there's not really a whole lot of information right now out here around this area. So, you know, this is an area I'm going to continue to watch, go out and check for updates pretty frequently. In June of 2020, items related to laboratory add-on tests were added to the OIG action plan. The Centers for Medicaid and Medicare, so CMS, they relaxed the rules related to COVID-19 testing and other associated diagnostic laboratory testing so that they no longer required an order from the treating provider or the nurse practitioner. And again, this is only during the public health emergency. So while we're in the middle of this emergency, after the emergency, an order will be required again. The issue is that the relaxation of the order, the order requirement allows for more leeway for fraudulent billing and unnecessary add-on testing. So basically what we're going to do is this OIG study will allow Medicare claims to basically be tested and trended to see if there was unnecessary add-on use for respiratory pathogen testing, allergy tests, and genetic tests. So being able to identify patterns for billing laboratories that, maybe were not appropriate. And again, there's not a lot of information out here around this right now. We just know that with the relaxation of the orders, this could be an area of vulnerability. So we want to make sure that we understand what those controls are once they're released and that we add this category to our compliance plan. Moving over into the 2 midnight rule. In the 2 midnight rule was basically established as a policy to be able for organizations to be able to establish criteria to use to determine when a patient's admission is reasonable and necessary for payment purposes under Medicare Part A. And when we talk about the 2 midnight rule, what that means is that the patient's admission is expected to cross 2 midnights. So the patient is an inpatient in the hospital at midnight on 2 days in a row. But there are exceptions to this. The inpatient only list is the first exception. So we know if a procedure is on the inpatient only list, it doesn't matter how many days they're going to be in the hospital. The whole goal here is that CMS is telling us if the procedure that you had performed is on this inpatient only list, we will not pay for this service unless you are an inpatient in the hospital. And that is the exception in itself. When we look at the second exception, which is the provider's decision to admit based on his expertise or the patient's circumstances, basically what we're looking at here is that the provider believes that the patient's condition requires inpatient care, and it's up to him at that point to provide the supporting documentation in the medical record that the case managers or whoever has to go out and get the stay approved can use to assure that the patient's diagnoses and those reasons that the physician has documented in the medical record will pass the interqual or whatever criteria that they're using to get the patient's stay approved. So if the patient is sick and the provider documents that, and he documents the unique situation that that particular patient is facing, along with his decision that he feels it's in the best interest of the patient, that serves as the second exception. 2021 begins the 3-year elimination period for the inpatient only list. And, we really hit the ground running this year. For 2021, there will be 300 musculoskeletal services removed from the inpatient only list this year. And the big thing here that we need to remember is once those procedures are removed from the inpatient only list, they are subject to the 2 midnight rule. So the patient's admission is expected across 2 midnights. When we look at the controls for the 2 midnight rule, a lot of these are known. The conditions of participation, the Medicare conditions of participation are very clear, and we know what is expected to be documented within the medical record. There's 4 controls here. Each of them have bullets underneath them. So we've got 4 slides of controls with bullets that we're going to walk through. The majority of it is what we already know. It just has to be documented within the medical record. So the inpatient status order is completed prior to discharge. So they're going to test when they pull these charts. So when we're talking about obtaining a sample of the medical records that meet the scope, we're talking about inpatient records. And they're going to test to see that the physician order is in the medical record, that the order was provided by a qualified physician, the order was provided at or before the time of the inpatient admission, the order was signed, dated, and timed prior to discharge by the physician, that the language clearly defines the inpatient status, so we can see that there's an order for an inpatient admission, and they're going to test that order for signature, the order and signature for legibility. Most organizations now are already up on the EMR. I think everybody is up on an EMR of some sort. So a lot of these are going to be date and time stamped. And then they're also going to look to see that we're noting any type of variance or recording anything, any findings that we have that are in work papers. So if there's any type of variance and like we're using papers that are not within the EMR or something that's not scanned into the medical record, that we have those things documented. Anything that pertains to the patient's care is there for them to be able to review. The second control is medical record documentation includes all elements required for inpatient status. So they're going to test the record for the reason for admission. They're going to locate that the documentation includes the estimated time the beneficiary is expected to be in the hospital. They want to validate that the patient stayed for 2 midnights. If the patient was discharged prior to the second midnight, they need to find the documentation that explains why. Why did they go home early? If appropriate, they're going to test for documentation of post-hospital care. So in this situation, a patient went home and is going to require home health. We need to make sure that we've got documented in there. They're leaving the hospital, but this is what they need following their discharge. And documentation is in there that supports the care that was ordered once the patient leaves the hospital and goes home. And again, note variances and record any and all findings in work papers. I don't really anticipate we're going to see much by way of observation because the whole goal of the 2 midnight rule is for inpatients, but there were some controls out there, so I wanted to go ahead and add it into this presentation. When we look at observation status, we're looking to see if the status is correct. So they're going to test whether the patient was appropriately assigned to observation. Did they meet the criteria for observation? Did the test that the physician order is written in language that clearly defines the outpatient status of the patient in observation? They're going to test that the order was signed, dated, and timed. They're going to make sure that the documentation supports observation services following outpatient services. And then again, note variances and record any and all findings in the work papers. And the last control here is a properly completed claim is submitted for all cases. So they're going to obtain the UB04 for all cases in the audit and take a look at them to make sure that they are appropriate, that the status is appropriate. So they're confirming that the bill type was consistent with the physician's order. They're going to validate the accuracy of the discharge status code. If voluntarily reported, they're going to test to make sure that the occurrence code 72 is accurate. They're going to determine that the date of admission was accurately reported and consistent with the date of the inpatient order. If applicable, they're going to test the condition code 44 was accurately reported. And then if observation hours were reported, they were going to check to make sure that there is at least a minimum of 8 hours there. If there's not a minimum of 8 hours there, then we did not pass that control. And that's an area with observation that I see very frequently, that we won't have the minimum amount of hours recorded. Sometimes they're there, they're just not recorded. So we need to make sure that whether we're missing them and the patient really didn't have the correct amount of the minimum amount of observation hours that's needed, we also need to look to make sure that the documentation supports that if they are there. Those are all missed opportunities, very frequent missed opportunities. And then again, note variances and record any and all findings in work papers. And that brings me to the end of the presentation. These are the sources that I use. There are a lot of sources out there relating to the Office of Inspector General and their work plan. A few things that I just wanted to call out. We need to remember that this is only February, so we're pretty early in the year. There's going to be changes. There are a lot of areas where we still don't have a lot of information out there. And I would just remind you that it's going to be very important to stay on top of the OIG work plan and to go back and check for those updates to make sure that you're capturing all of those updates that are necessary for your compliance plans. And I want to thank you again for joining. I've got the slide up here. Angela Hardesty would be a great person for you to reach out to if you have questions, comments, concerns, if you have an idea for another webinar that you would like for us to put together, or if you have any staffing needs within your organization. Angela's phone number and her email address is there. thank you again for joining. I really appreciated the time with you today, and I hope you all have a great day.